Hello everyone, myself Dr. Namrata Vithalani. I am practicing as a physician at Definite Cure Clinic, Surat. Today I have started recording this video basically for the medical students, especially for those who have started just learning the medicine. In basics, approach to a patient with cough, any MBBS student or a medicine student, it is a basic to start with. Even our PG teacher, they first started us with the symptomatology, so different symptoms and approach to them. So if we talk about approach to a patient with cough, so first of all we have to consider its duration. So whether it is acute, subacute or chronic. So acute cough, that is less than 3 week duration, subacute, that is 4 to 8 weeks, and more than 8 weeks is the chronic cough. This differentiation into a duration, it is important because the symptoms, the cause behind the cough, it might give us an important clue from the duration. Say for acute tracheobronchitis, any viral illness or toxins, dust, fumes, any temporary exposure to an infectious agent, inflammatory agent, or any other noxious stimulus which leads to the dry cough, that is of a short duration, that most of uh, us we have commonly experienced once in a while. So the acute tracheobronchitis due to any infectious or allergens, it is of short lasting duration. Then comes the subacute and chronic. So we have divided this cough, it might be a non-productive or a productive cough. So commonly the causative agent or a cough which is generally originating from the upper respiratory tract, it is a non-productive and which affects the lungs and parenchyma. Commonly it is a productive cough. This rule sometimes may not be applicable, but in general it is seen. So, in a productive cough which affects the lung parenchyma, common causes, they are pneumonia, bronchiectasis, tuberculosis, lung abscess, lung malignancy, even cough with sputum production or a blood in sputum. It might be seen in cases of tuberculosis, pneumonia, bronchiectasis, malignancy. This cough, they are of a long duration, that is a more than 8 week origin. So, duration of the cough, it is an important clue to the causative or the etiology. Say for a long-standing cough, productive cough with an evening rise of temperature with a significant amount of weight loss over a period of month, which is accompanied by an evening rise of temperature, which might point towards its etiology being tuberculosis. So another is the malignancy. An elderly male patient smoker or a female patient elderly male patient smoker or an elderly female patient with a long standing cough or a dyspnea with accompanied by a significant amount of weight loss, often accompanied by the hemoptysis, might point towards the etiology being malignancy, and which may lead to the malignant pleural effusion also. So even tubercular pleural effusion or a malignant pleural effusion, that might present with a long standing cough with breathlessness and weight loss. So these are an important clues to the etiology. Another important cause to the cough is the interstitial lung disease. So, long standing non productive cough, often accompanied by the hypoxia, breathlessness, often exertional dyspnea. And on clinical examination, you might find an inspiratory fine crackles, and in X-ray, honeycombing, and CT scan, other typical features of interstitial lung disease. So this long-standing cough, that might be due to the interstitial lung disease. Another important etiology to the cough, basically non-productive cough, it is a drug-induced, that is a AC inhibitor related. The mechanism is due to the production of the bradykinin and subsequent leading to the cough. So changing to another antihypertensive agent if the cough is distressing might help the patients. Another is the GERD, that is the gastroesophageal reflux disease, which may lead to the non-productive cough. But often many patients with chronic acidity symptoms, or you mean say upper GI symptom, reflux symptoms, that might not also have cough, but in those you do not find on evaluation or X-ray, CT scan, you do not find the proper etiology, and if it is accompanied by the symptoms of heartburn, acidity, you might consider in such patients, and so treatment accordingly might help the patient. Uh, we 24-hour pH manometry, so pH monitoring, that is the diagnostic of GERD, but if we do not do the barium swallow, that might also help in the diagnosis of chronic cough which is related to the GERD. So another cause is the asthma. So cough variant asthma, or asthma accompanied by the symptoms of the breathlessness, that is a very important cause of the cough, which is common in general population. On evaluation, you do not find any infective etiology, X-ray being clear, and PFT also might help in this patient. On clinical examination, you might find the wheeze or rhonchi in this patient, and they respond beautifully to the bronchodilators or steroid or routine asthma medications. Another important cause for the cough, it might be the cardiovascular. So in the cardiovascular causes, the acute pulmonary edema, or you can say the left ventricular failure, so it is an important cause for the cough. So specifically this kind of cough, it is accompanied by the exertional dyspnea or paroxysmal nocturnal dyspnea, and typically we say pink phthis sputum, but the extent to which the patients land up in these situations, they are usually critically ill, and echocardiography, X-ray, ECG, and other clinical pictures, crackles, hypoxia, bilateral infiltrates on the X-ray, they might provide, and other clinical features of suggestive of cardiac illness might point to the etiology of the cough. In this patient's cough, other than cough, other symptoms, they are of many. They are of major concern other than the approach to the cough. So cardiovascular causes like that, non-cardiovascular or respiratory causes we have discussed of long duration, other non-productive cough, GERD. So basically what we commonly see is the any infectious, inflammatory, neoplastic etiology that may lead to the cough, which may affect upper respiratory tract or lower respiratory tract. In another important cause is the chronic obstructive pulmonary disease, that is the COPD. We say chronic bronchitis, that is a cough with expectoration for more than 3 month consecutive duration in a 2 year period. So in a smoker's cough, in a patient is smoking since long, more than 10 pack years, or elderly patient with cough with expectoration and with other typical features suggestive of COPD, so that is an important cause. So in a respiratory obstructive airway disease, asthma, COPD, tuberculosis, malignancy, interstitial lung disease, pneumonia, bronchiectasis, all these are very important causes of cough. Another non-productive drug-induced GERD, they are also very important causes. And in the cardiovascular, acute pulmonary edema or left ventricular failure, it is an important cause for the cough. And you might proceed with the routine blood investigations, to find any infectious etiology or allergic. Eosinophilia may also be present in patients with the allergy. Routinely you should do a chest x-ray. If you do not find any cause, you may proceed with the CT scan. Sometimes if you clinically suspect obstructive airway disease, you might proceed with the pulmonary function test. With this much of evaluation, in most of the cases you will find the etiology of the cough and manage appropriately. Thank you.